Hey guys, welcome back to our channel Gyri N Sulci. Today, we will move on from the developmental part of diabetic ketoacidosis and dwell upon its clinical characteristics and the management part. So, a patient comes to your clinical setup and he tells you about normal GI problems such as nausea or vomiting. He also feels thirsty every now and then these days and might be urinating in excess as well. He also complains of some sort of abdominal pain, and finally, he complains about difficulty in breathing at several occasions. And then, when you physically examine the patient, you find out that the person is dehydrated, and because of which he might be hypotensive as well. On examining the breathing pattern, you find out that the person is hyperventilating, and on auscultation, you hear the deep and labored breath, and this breathing pattern is known as Kussmaul's breathing pattern. Now use your headphones and hear these Kussmaul's breathing sound. On examining his abdomen, you might find some abdominal tenderness, which is common in pancreatitis or surgical abdomen. The person might also feel a bit lethargic to you, and sometimes a patient is brought to the hospital in comatose condition. These clinical features are suggestive of the fact that the patient is either suffering from diabetic ketoacidosis, denoted here as DKA, or from hyperglycemic hyperosmolar state, denoted here as HHS. Therefore, we need to confirm the diagnosis by evaluating various parameters such as serum glucose, pH, serum ketones, anion gap, and serum osmolarity. In case of DKA, the serum glucose levels are in excess of 250 mg per deciliters, whereas in case of HHS, they are in excess of 600 mg per deciliters. Since the phenomenon of acidosis is well marked in diabetic ketoacidosis, the pH levels are less than 7.3, whereas in the case of HHS, they are in excess of 7.3. As the process of ketosis occurs in diabetic ketoacidosis, the ketone bodies are present in serum or urine, whereas in the case of HHS, ketosis doesn't happen. Therefore, the ketone bodies are absent in the case of HHS. The anion gap is in excess of 12 in DKA, whereas in case of HHS, it is less than that of 12. Serum osmolarity is variable in case of diabetic ketoacidosis, whereas in the case of HHS, it is present in excess of 320 osmoles per liter. Then, after confirming the diagnosis, we admit the patient to the hospital. We rush the patient to intensive care unit if the plasma pH is less than that of 7. Then first of all, we treat the problem of dehydration by replacing the fluids rapidly. We do it by supplying normal saline, that is 0.9% saline intravenously. We begin with 1 to 2 liters of normal saline every hour. Then after some time, we will recheck the sodium and glucose levels. If the sodium levels are still in low concentration, then we will continue with normal saline at the rate of 250 to 500 ml per hour. If the problem of sodium depletion has been corrected or the sodium is present in excess, then we reduce the saline to half of normal saline, that is 0.45% of saline, and we supply it at a rate of 250 to 500 ml per hour. If the blood glucose level reaches 250 mg per deciliter or is less than that, then we don't want to drop it below this level. So we add 5% glucose with half of normal saline and supply it at a rate of 150 to 250 milliliters per hour. And then we will try to replenish the insulin levels whose depletion has caused the root cause of diabetic ketoacidosis, that is hyperglycemia. We'll begin with IV push of zero point 0.1 unit insulin per kg of body weight. Then we will continue with the same concentration every hour. Then we will check the plasma glucose levels. If the plasma glucose levels are less than 200 milligram per deciliter, then we will lower the unit to 0.02 to 0.05 unit per kilogram of body weight every hour. And finally, we'll try to correct the hyperkalemia caused due to excessive diuresis. But supplying the insulin also aggravates the problem of hypokalemia. So we must have an idea about the total body potassium levels before supplying potassium. If the body potassium levels are less than 4 or 5 milliequivalents per liter, then we can supply the drip of potassium at the rate of 20 to 40 milliequivalents per liter. But if the total potassium level drops below 3.3 milliequivalents of liter, then we must first discontinue the insulin drip and then supply the potassium at 20 to 40 milliequivalents per liter. The purpose of our therapy is to bring back blood glucose in the range of 150 to 200 milligram per deciliter, decrease the insulin infusion to 0.02 to zero point 0.1 unit per kg of body weight every hour and resolve the problem of acidosis. There are some cautions too which are needed to be taken during the course of this therapy, such as regular monitoring of vitals such as blood pressure, pulse, respiratory rate, anion gap, and mental status of the person. We must identify the precipitants causing diabetic ketoacidosis at the earliest. We must also measure capillary glucose every 1 to 2 hours and electrolytes every 4 hours for the period of this therapy. If the potassium levels are less than 3.3 milliequivalents per liter, then the insulin drip must be withdrawn, and first of all, we must do the potassium correction. So that was all for the management of diabetic ketoacidosis. Hope this video was clinically enlightening for all of you. So that's all for today, guys. Hit the like and subscribe button, post your queries in the comment section, and stay tuned for the journey of advanced cognition.